Please welcome, today is our maternal mortality series workshop. Thank you so much for everybody who is joining us. I would like to welcome our maternal medical director, Dr. Jessica Young.
Hi, thanks, Bonnie. I'm Jessica Young. I'm the State Maternal Medical Director for TIPQC. And today we will have 3 presentations. So we're just going to jump right on in because we're a little behind on time. Our first speaker today is Julia Wood. And Dr. Wood will be discussing postpartum mood disorders. Dr. Wood is a psychiatrist who practices in Knoxville, Tennessee. She's a graduate of Vanderbilt University School of Medicine and completed her psychiatry residency at Harvard, Massachusetts General Hospital. She specializes in psychiatric disorders in women and postpartum mood and anxiety disorders, and is on the board of the Tennessee Postpartum Support International. She lives in Blount County with her family, and I'm pleased to call her a dear friend. Welcome, Julia.
Thank you. All right. Just waiting for my slides to pop up. Great. Thank you. So I'm going to talk today about perinatal mood and anxiety disorders. I have no financial disclosures. I do volunteer with Postpartum Support International, otherwise known as PSI. If you're not familiar with PSI, it's been around since 1987. And its mission is to promote awareness, prevention, and treatment of mental health issues related to childbearing. And PSI has a variety of resources available both to professionals and to patients, and I will be sharing some of those resources with you today. I hope they'll be helpful to you. Next slide. So when I gave birth to my first child, my son, I was a resident at Mass General Hospital, and I gave birth at Massachusetts General and was in a room overlooking the Charles River and the Esplanade. And what I remember most about my time at the hospital postpartum was my bedside nurse. She gave me these little elevator pitches on all sorts of subjects and basically gave me a crash course in how to be a mom. She taught me how to bathe my son. She taught me how to breastfeed. She showed me nursing positions. She told me what to watch out in terms of his diapers, in terms of his umbilical cord site. And she gave me a talk on postpartum depression. She told me what was normal. She told me what to look out for that should cause me more concern. And she told me what to do and where to get help if I needed it. And I was a psychiatry resident at the time, so I remember it well. And it was just an amazing experience to get all of that information. Next slide. So in addition to giving you some tips on treating postpartum mood and anxiety disorders today, I hope to inspire you to develop your own elevator pitch about postpartum depression if you don't already have one. And this really should just be a talk 1 to 2 minutes long to share with moms when they are in prenatal visits, at hospital discharge, in postpartum appointments. And you should tell them about what's normal, the baby blues, what should cause them more concern, and how to get help. Next. And listen, I know that you are busy people and you have more on your plate than any one person should be asked to handle. And I wouldn't ask this of you if I didn't think that it really could make a difference in the life of the mother-child dyad that you help bring into the world. Next slide. Do you know what an ACE score is? ACE stands for Adverse Childhood Experiences, and the ACE questionnaire is a 10-point questionnaire that asks about childhood experiences such as parental divorce, neglect, verbal, sexual, physical abuse. Next slide. And the higher your score on the ACE questionnaire, the higher your ACE score, the more likely you are to experience problems in adulthood, ranging from depression to substance use disorders, including cigarette smoking, and chronic medical conditions like cardiovascular disease and obesity. And 2 of the questions on the ACE questionnaire relate to parental mental health and parental substance use disorders. Next slide. And so I would argue that by treating maternal depression, we can have a ripple effect on the health of a child for a lifetime. Next slide. Maternal mental health problems, including substance use disorders and depression, are also a major contributor to maternal mortality. Substance use disorders contributed to 1 in 3 pregnancy-associated deaths in 2017 and 2018, and mental health problems contributed to 1 in 4 deaths. Next. Treating or preventing maternal depression is all the more important because it is so common. 1 in 5 women report having a perinatal mood or anxiety disorder. If you're in a busy OB clinic seeing 20 women in a day and you give each one of these women your elevator pitch on postpartum depression, 4 of these 20 women can benefit from that information. That is a big return on your investment of time. Next slide. So what I hope to teach you today is how to recognize risk factors for postpartum depression, how to screen for postpartum depression, how to make the diagnosis and to differentiate from the baby blues, how to initiate treatment, and I hope to give you some resources to include in your elevator pitch. So that's a lot. Next slide. Next slide. So while I advocate talking to all women about perinatal mood and anxiety disorders, let's talk about who is most at risk. Next. Women with a history of depression. Pay particular attention to whether a woman was taking medication prior to pregnancy. Women who are treated for depression with medication and stop for pregnancy have a 50% chance of having a relapse of depression during pregnancy. Next. Depression during pregnancy is the #1 risk factor for postpartum depression. And so while we certainly want to minimize medication exposures for baby, we want to treat depression in pregnancy. And most studies looking at medication in pregnancy find that the outcomes of medication during pregnancy, antidepressant exposure, most of the risk comes from the underlying depression itself. And so treating for depression with medication certainly helps mom, helps her feel better during pregnancy, and reduces her risk of postpartum depression. Next. Substance use disorders also increase the risk of postpartum depression. Opioid use disorder is the most deadly disease we have in psychiatry, and we want to be addressing this aggressively during pregnancy in conjunction with mental health problems. We want to take this opportunity during pregnancy when women are connected to care to help them plan for the postpartum period, because it's a time of particularly high risk, both for relapse of addiction as well as mental health problems. Next. A traumatic event during pregnancy increases your risk of postpartum depression. And of course, the pandemic has been a time of hardship, loss, and trauma for many. Next. And poor social support is also a risk factor. And a little later in my talk, I'll introduce you to some social support resources that you can share with your patients. Next. Recognition. Next. So all women should be screened for postpartum depression at 6 weeks postpartum and also during pregnancy and 2 weeks postpartum for those at high risk. And the most commonly used tool to screen for postpartum depression is the Edinburgh Postnatal Depression Scale. I imagine that many, if not all of you, are familiar with this. So the Edinburgh, or the EPDS, has questions that are more specific to the postpartum period, and it's freely available to use. A positive screen is usually considered equal to or greater than 13. And so if you're using this screening instrument, anybody who scores 13 or who answers in the positive to the question about suicidal thoughts needs to be passed on to the medical provider for further discussion. Next. So the EPDS is a screening tool, which of course means if you have 13 or more on the EPDS, you need further questioning, but the EPDS does not actually make the diagnosis of depression. A diagnosis of depression requires that you answer yes to either a question about having depressed mood most of the day, nearly every day, or a loss of interest in activities for more than half the time for 2 weeks or longer. And in postpartum depression, a lot of women will not describe feeling depressed. They'll describe feeling very anxious. And you need one of these 2 symptoms plus another 3 or 4 of what we call the neurovegetative symptoms. And as a reminder, to diagnose depression, the mnemonic we use for the symptoms is SIG-E-CAPS. And these symptoms stand for, the S is for sleep, I is for interest, loss of interest in activities, G, guilty ruminations. Women often have a lot of guilty ruminations over their mothering. E is for energy, either an increase or a decrease. C is for concentration, difficulty making decisions, feeling mentally foggy, having a trouble keeping your mind on things. A is changes in appetite. P is for psychomotor slowing or psychomotor agitation, and the S is for suicide. And again, these symptoms should be present for 2 weeks or longer. Next. So the baby blues is common. Up to 80% of women will experience it. And I tell my patients while they're pregnant what to expect postpartum. I tell them that they may feel more weepy after delivery. They may have more anxiety. I prepare them that these symptoms can feel pretty intense. They can feel pretty unusual for some women. But I also tell them that they're not lasting. So they happen in relatively brief periods of time, and then they go away. And between the periods of time when people are feeling anxious or weepy, they feel pretty normal. They're able to bond with their baby. They're able to bond with their partner. They're tired. And when they lay down for sleep and have an opportunity to sleep, they can usually sleep without great difficulty. So between feedings overnight, or if someone else is able to take care of baby during the daytime, mom lays down to rest, she's able to sleep. And also these symptoms, they go away 7 to 10 days postpartum, and they tend to disappear. With postpartum depression, on the other hand, women have a more pervasive sense of high anxiety. And often when baby sleeps, mom is exhausted and lays down to sleep, and she cannot sleep. She's just lying there awake, worrying often. She may lose a lot of weight fairly quickly due to loss of appetite. Her energy may be very low. She may be having someone else come in the home to help care for her baby because she's unable to do it herself. Or she may feel tired but wired. So she's exhausted but can't relax and feels like she can't sit still. She may feel like she can't bond with her baby. She may feel disconnected, and she may feel a lot of guilt about this. And she may even feel like other people, including her family, would be better off without her. Next. So I'd like to give you a few practical treatment tips on initiating treatment with medication. Next. So I'd encourage you to be comfortable with at least 2 or 3 first-line medications for depression. In postpartum depression, I most commonly use probably the same medications that you're using, sertraline and escitalopram. I choose sertraline first in a medication-naive woman due to low passage into the breast milk. But if someone has tried sertraline and failed it or had problems with it, I choose escitalopram. And with both of these medications, I start low, usually at half the typical starting dose. So for sertraline, I start at 25 milligrams, and for escitalopram, I start with 5 milligrams. And I tell people, take this dose, the starting dose, for 6 days. And then if you're feeling okay and not having any problems with the medication, double it and go up. So go up to 10 milligrams for escitalopram or 50 milligrams for sertraline. A lower dose certainly causes more side effects, but it doesn't confer less risk. And so what I have seen a lot is women coming who are pregnant, and they'll be on 25 of sertraline, and they will believe that being on this lower dose somehow confers less risk to the baby, which it does not. And so we really want to treat women and treat the symptoms to remission and not worry about the dose. So when starting the medication, I tell people about side effects. I tell them that the most common side effects are nausea and diarrhea. I also tell them that if you run anxious, you may feel a little bit more anxious when you're first starting these medications. We start low to try to prevent that from happening. But if you're taking 25 of sertraline and on day 6, you're still feeling nauseated or you're still feeling anxious, don't go up. Stay for another 4 days so that you've been on this low dose for 10 days, and then try to go up if the symptoms have resolved by that point in time. So again, I start low, but I don't stay low, and I try to get women to a therapeutic dose as quickly as possible. And then I wait a few weeks to see if it helps. Next slide. The black box warning. So all antidepressants carry a black box warning about new suicidal thoughts emerging with treatment in people under the age of 25. So if you're treating people who are 24 and under, you need to know about this and be talking about this with those patients. Next. So the black box warning only applies to people under the age of 25. If you look at studies of people who are 25 and older, the incidence of suicidal thoughts was the same on active medication and on placebo. Next. However, in studies of antidepressants in children, adolescents, and young adults, the incidence of suicidal thoughts was double in those on medication versus placebo. And we don't really understand why this is, but we do need to tell patients about this. Next. And we need to do so in a calm manner to not create panic. Next. So what I tell patients is that there's a warning on antidepressants for people under 25. I say, there's something about the developing brain that can cause medication to interact differently in people under the age of 25 years old. In large studies, researchers found that young adults taking medication had more incidence of new suicidal thoughts than people taking placebo or a sugar pill. And I say, it was very rare. It only happened in 2 to 4% of people. I don't think it's going to happen to you. But if it does, you need to know what to do. And then I tell them what to do, which in my clinic is to call me. And we usually stop the medication. But I try to present this very calmly, matter-of-factly, and let them know that it is this low number of 2 to 4%, because I learned the hard way when I started telling people about the black box warning. Next slide. So what about bipolar disorder? Bipolar disorder is important to identify in your patients, as women with a history of bipolar disorder do have an increased risk of postpartum psychosis, and they have a very high risk for postpartum depression. But the challenge I find in treating patients is that many people, especially if people have seen multiple treaters in the past, many people come to me having been diagnosed at some point in the past with bipolar disorder. And sometimes it's hard to tease out who really has bipolar disorder and who does not. And I certainly don't expect any of you to be trying to tease out who has bipolar disorder and who doesn't. I'm not going to make you into a psychiatrist today, but I want to give you a few tips to help you be on alert. To know who to really worry about. Next. So bipolar 1 disorder is a disorder that includes episodes of mania. So women will have episodes of little to no sleep, high energy, they're either euphoric or they can be very irritable, and they act unusual. And they often become psychotic. They can have delusions, and people around them know that they are not themselves. And sometimes people can tell you quite obviously, what you have bipolar disorder, what happens when you get manic? Well, I had this episode where I didn't sleep for several days and I drove to Chicago because I thought that I was going to meet my husband there. And, I ended up in the hospital. Inpatient hospitalization is a big red flag, obviously a history of psychosis. And also history of treatment with lithium is also a red flag. And if you have a woman who has these red flags, has a history of bipolar disorder, was on medication prior to pregnancy and is not now, it would be wise to have her see a psychiatrist, to have a plan in place postpartum to get help if she needs it. Next. So bipolar 2, this is a lot harder to tease out because women with bipolar 2 disorder have episodes of hypomania. So they have times where they needed less sleep, but they still slept some. They had high energy and maybe a lot of irritability, and they may have gotten themselves into trouble with some impulsive behavior. When you have symptoms of bipolar 2 disorder overlapping with substance use, things get really murky. And so if you are meeting someone in the postpartum period who is depressed, who's not on medication, and who tells you they have a history of bipolar disorder and they don't have any of these red flags, I just encourage you to get curious and to ask some more questions to figure out what you may or may not be comfortable doing. Next. So again, consider if the symptoms were occurring in the context of substance use. Next. Specifically, I would ask how long she's been off medication and what medications were helpful in the past. You'd be surprised how many people tell you, I have bipolar disorder. Prozac was so helpful for me. I mean, there you go. Next, I would specifically ask about SSRIs. If someone told you that SSRIs made them worse, I'd have some pause. But if they simply said, oh, they didn't work, and again, there were these other extenuating circumstances going on, such as substance misuse, I might consider starting a low dose of an SSRI while you're waiting to get somebody in with a specialist. Next. And also consider how soon you're going to be able to get this person in to see somebody. Next. I put this down here in red. Someone needs to prescribe. Just as a reminder, if I'm seeing someone who's depressed postpartum and I don't feel comfortable prescribing the medication and I can't get them into treatment for the next month, a person is without any treatment for the next month. And so we need to, work together to figure out either how to get someone in sooner or see if this might be somebody you would be comfortable prescribing medication to. Next. And here's a potential resource. So PSI has a perinatal psychiatric consult line, and this is free of charge and available to any prescribing clinician. So if you are seeing someone postpartum, or let's say you're seeing someone at the end of pregnancy and she's depressed, and you say, oh, what have you taken before? And she says, oh, I took Latuda, it was really helpful. And you are not comfortable prescribing Latuda, you haven't prescribed Latuda before, you don't know what to do, you can call this line and you can talk to a perinatal psychiatrist and you can run some things by them and get their help and advice in caring for your patient. It's not a hotline, so you unfortunately can't jump out in the middle of your visit and talk to someone, but you can get an appointment within 1 or 2 business days. This is the telephone number, 1-800-944-4773, extension 4, or you can go to postpartum.net, which is PSI's website. And if you navigate through there, they have a place that you can sign up for an appointment online. So if you're a busy doctor or nurse practitioner seeing patients in the clinic, you can have your staff call or go online and make the appointment for you. Next. So of course, medication is just one possible treatment. I'm going to touch on some other treatments. Next. So sleep. I always prescribe sleep to my patients. Of course, I am usually seeing people who are pregnant, who are already taking medication, and we're really planning pretty aggressively for the postpartum period. And we know that sleep alone improves depression outcomes, even outside of the postpartum period. So I tell all of my patients to get at least a 4 to 6 hour chunk of sleep uninterrupted. And this, of course, means that if mom is breastfeeding, that she will need to pump before she goes to sleep, and someone else may need to give a bottle overnight while she's sleeping. If mom is having a lot of trouble sleeping due to anxiety and there's no history of substance use disorder, I prescribe a low dose of lorazepam, usually 0.5 milligram up to 1 milligram, to help mom sleep. Next. Peer support groups can also be helpful for women with postpartum depression. And this is another resource that you can access through Postpartum Support International. So this website, postpartum.net, if you go to their website, they have actual links for online peer support groups. There are some local ones as well. Right now with COVID, I know the one we have in the Knoxville area is virtual. And then there are these national virtual support groups as well. And last time I looked, if a woman went online today to get into a support group, it was about a week before there was an open support group. But for someone who's not in acute crisis, I'd say that's pretty good. And of course, these are all free of charge, and they have some specific support groups for Black moms, for NICU moms. They have groups for dads. So they have all sorts of different groups that people can sign up to be a part of. Next. And PSI also has a helpline. So this is for patients themselves. And I would encourage you to give this out at hospital discharge, in prenatal appointments, at postpartum appointments. This helpline is manned by volunteers, most of whom have lived experience with perinatal mood and anxiety disorders, and they can lend a helping ear, and they can also connect women to resources. So they know about the support groups that are available. They have a list of therapists and medication providers and doulas and other resources of people who specialize in perinatal mood and anxiety disorders and can connect people to care. Like the provider consult line, it's not a hotline, so you can't get someone immediately if you're in crisis, but someone will call you back within 24 hours, and they can be very helpful, and it's all free of charge. Next. So back to the elevator pitch. So I hope that that you will take a few minutes today to jot down some ideas for your elevator pitch. Again, share with women about the baby blues, what's normal after delivery. It's normal to feel some weepiness. It's normal to feel anxiety. But between these times of feeling bad, you should feel you're able to bond with baby and you're able to sleep. If these symptoms are pervasive, if they're long lasting, especially any thoughts of self-harm, you need to get more help. And in addition to providing perhaps your own information as their clinician, provide the PSI helpline next. And this is the helpline again. Okay. You go back one. Here we are. 1-800-944-4773. And next. So if you want to learn more about perinatal mood and anxiety disorders, treatment, diagnosis, there are loads of training opportunities through PSI. And there are scholarships available for discounts. This is my email, wood, W-O-O-D, @knoxvillepsych.com. So if you want to take a training opportunity and you want to apply for a scholarship, please reach out to me and I can connect you to the right people at PSI. And additionally, in our PSI chapter in Tennessee, we're always looking to partner with organizations and individuals. We have a volunteer working board. We're always looking for new members and new volunteers, and I would be happy to talk to anybody about joining us and working together to help patients. Thank you.
Thank you. And next we have Dr. Connie Graves. Dr. Connie Graves is our state leader here at TIPQC, and she is also a phenomenal doctor at St. Thomas Midtown. And we'll go right into her. Like when I clicked off of it, Dr. Graves, are you on?
I'm here.
Perfect. I'm trying to get it to go back into letting me. Hold on 1 second, Dr. Graves. I apologize.
That's okay.
It's advancing on my side, but when I'm sharing, what do you see?
I see training opportunities.
I see.
Make sure there you go.
So thank you for that great talk on postpartum mood disorders. And so for the next time, I'm going to share a little bit about postpartum hemorrhage. And one of the things I want people to remember, and one of the things I've learned in dealing with our postpartum preeclampsia clinic, is that often when women have a traumatic delivery, we don't pay enough attention to the postpartum mood disorders that occur with that delivery. We think we saved the day, but the patient is actually traumatized significantly by what happened to them during that time. So I really thank you for bringing that to our attention. Postpartum hemorrhage is the leading cause of death worldwide. I just recently got finished doing a critical care course for Ethiopia. And one of the things that they really were interested in is how to decrease their risk of postpartum hemorrhage. It accounts for about 30% of our direct maternal deaths, and is still one of the leading causes of maternal morbidity and mortality in the United States. Next slide. Now, I like history, so this is one of the slides I include. And the reason I include this slide is for a number of reasons. One And my grandmother was born in 1900, and in 1900, the average lifespan for a woman was age of 40. The reason that most women died was because of childbirth. And one of the reasons that women died in childbirth was because there was no true ability to perform a blood transfusion. As Black History Month has just passed, that all changed when Dr. Charles Drew figured out how to store blood and to be able to transfuse blood and develop the first blood banks. That's when obstetrical care moved to hospitals and became much more safe. In addition to that, around that same time, antibiotics became safer. And so we saw at that point a dramatic decrease in maternal morbidity and mortality in this country due to those two discoveries. Next. Well, in 2020, the Joint Commission has recognized that there are two things that are driving maternal mortality in the United States. Well, really three. But the first one, of course, we talked about already, was the cardiovascular diseases, which we're also working on in the state of Tennessee. Secondly was hypertension, and third was hemorrhage. So they came out with some very specific guidelines in which they would like us to follow. Next, they would like us to reduce the likelihood of harm from maternal hemorrhage. They would also introduce 13 elements of performance that will be applicable to Joint Commission accredited hospitals. And what this means is that every hospital will have to meet these requirements in order to be able to provide obstetrical care. These requirements are within the provision of care, the treatment, and services that the hospital has to provide to women. Next, it's designed to improve quality and safety of care and to provide women with care during all stages of the pregnancy and postpartum period. Next. Continuing with the Joint Commission's, the Joint Commission accreditation, one of the things is that there are several elements of this particular elements of performance that we have to meet. Next. The first is we're going to complete a hemorrhage assessment on admission. We often think of a hemorrhage as they're going to hemorrhage only when they deliver. But we need to think of hemorrhage in a three-step process: antepartum, intrapartum, postpartum. We're going to develop a stage-based management plan in order to address each part of this time. Next, we need to have a dedicated hemorrhage supply kit on the units, and we're going to talk about that as we go forward. Next. And provide education to all staff and providers who treat pregnant women and women who are pregnant in the postpartum period, which means that we need to provide, and especially many of our level 1 and level 2 hospitals, education to surgeons, ED providers, and ICU providers. Next, we need to conduct drills annually, review hemorrhage cases, and then more importantly, provide education to patients and families. Next. One of the reasons we want to provide education to patients and families is often we send people home like with arcritas or procretas or previa, and we want patients to know when they should return to the hospital. How much bleeding is too much bleeding? Next. So what are the risk factors for postpartum hemorrhage? Prolonged or augmented labor, those inductions that we love, retained or abnormal placentation, which we're seeing more and more of. And it's not just the procreta we can see on ultrasound, but those sometimes occult accretas that only one part of the placenta is stuck, lacerations, operative vaginal deliveries, a macrosomic or a large infant, abruptions, hypertensive disorders which lead to abruptions, and a previous history of postpartum hemorrhage. In addition to that, there's some other factors I think that we don't often think of, including obesity, which is on the rise in Tennessee, high parity, those patients who've had more than 4 children, Asian or being Hispanic, which also has increased in our population, precipitous deliveries, or uterine overdistension. Patients who have twins, triplets, or in my case, I've delivered 4 sets of quadruplets and 1 set of quintuplets. Those types of pregnancies are more likely to bleed. Uterine infection, and then drugs that cause any type of uterine laxation. I used to tell my residents, when you're delivering twins who are on magnesium for their hypertensive disorder, you need to plan accordingly and have everything in the back ready to go when they bleed after delivery. Next. So, uterine atony is still the #1 cause of postpartum hemorrhage, followed by trauma and lacerations, followed by retained products of conception, and then abruption with atony or coagulation disorders, uterine inversion, of course, abnormal placentation, which is increasing. We had a procreator we just delivered. I have one in the hospital, and I have one that's coming into the hospital. And so therefore, that's just this month. So we're seeing more and more abnormal placentation. But also you have to keep in mind things like abruption and amniotic fluid embolism, which cause profound coagulation disorders. I just had one 2 Wednesdays ago when I was on call, because I often have those types of call days. And so therefore, those patients can consume a lot of blood products, not so much from the fact that they have a tissue injury, but from the fact they have consumed their coagulation disorders, coagulation products and things of that nature, coagulation factors. Next. So, atony still being the same, that's postpartum uterine atony. Then there's birth canal trauma that we often see with forceps, vacuum, retained products of conception, including those little pieces of placenta that sometimes get caught in the uterus, previa and accreta, and then of course the things that are not trauma, abruption, which consumes your coagulation factors, and amniotic fluid embolism. Next. Well, what are the causes of pregnancy-related death? This is from till 2016. And one of the things I would like to point out is that cardiomyopathy and cardiovascular conditions, these kind of all are combined over here. But if you will see that hemorrhage is still quite common as a cause of maternal death in the United States. Next. In the state of Tennessee, this is our 2018 data. You will see cardiovascular disease. I don't think we changed positions actually. Cardiovascular disease, preeclampsia, followed by hemorrhage as the leading cause. You saw in 2018, 6 deaths out of that N of 44 were due to hemorrhage. What about postpartum hemorrhage around the world? The incidence is difficult to establish. Like I said, I was in, we did a critical care obstetrical conference for Ethiopia. It was very interesting because the Ethiopian city had, in the city, they had many resources. And when I went to Ghana, they had many resources as well. But once you get outside the cities into the villages, I went to some place in Ghana and their definition of a postpartum hemorrhage kit was 1 bag IV fluid. So it is very clear that throughout the world, this is still something that we are working to establish and to try to figure out. Next. Again, there's no universal definition. How much blood loss is too much blood loss? And what we do know is that we've been prepared to have blood loss already. And of course, there are also very inaccurate clinical estimates of blood loss, which we're going to discuss. And then of course, the timely recognition. You know, I always say that obstetricians are used to seeing a lot of blood. Whenever I operate with my GYN colleagues and we do a C-section, the first thing they say is, you know, Connie, she's bleeding. I'm like, yeah, there. We're doing a C-section. It's okay. And then, you know, we get everything kind of tidied up before we proceed with the hysterectomy for their procreta. However, since we're used to seeing a lot of blood, sometimes we don't recognize when the patient has bled too much. And that is exactly what causes maternal death. Next. Well, again, what we see, and this is a pregnancy surveillance system, the 3 most likely causes of pregnancy-related death. On the day of delivery, hemorrhage leads the pack. And on day 1 through 6, hemorrhage leads the pack. In California, what they found is there were 2 reasons that there was an issue. One, if you look here, the first was failure to consult. That's one of the things I tell people. I've been operating for 30 years. Do I really need somebody in the room? Probably. I don't absolutely need to have another surgeon in the room, but having another surgeon or a couple of surgeons in the room can definitely help when we're having a chaos or when the emergency is going on. The second thing, so the failure to consult, ask for help, and the second thing was ineffective care. Farther down was misdiagnosis, and then of course the lack of continuity of care. The CDC rate of postpartum hemorrhage, and we're looking here, and what we're seeing is that postpartum hemorrhage with procedures to control hemorrhage. Now, one of the good things about quality improvement is I think you should, when we're doing these types of improvements, you're going to see an increase. So what we are really seeing here is, as we begin to call attention to postpartum hemorrhage, you saw an increase in the diagnosis of postpartum hemorrhage. And as you see an increase in diagnosis in the postpartum hemorrhage, you also see an increase in patient and appropriate treatment, including blood transfusions. Next. So how do we then take care of kind of bleeding when it occurs on our unit? I'm going to talk about it in several ways. First, identify the source of bleeding. I've had many times when I've called to the room about bleeding, and what happens is the patient has a bleeder in her vagina or somewhere else, and so people are giving out uterotonics, but that doesn't really help when the bleeder is not in the uterus. So first determine that your bleeding is coming from the uterus, and then administer the appropriate drugs. And we're going to talk about there's misoprostol, there is Pitocin, and one of the other things that I think that and Methogen. Methogen often is not used because of hypertension, but it is a very effective uterotonic drug. The second thing is that you need to apply direct pressure to the uterine cavity. If you're not inside the uterus, that's bimanual massage. And I'm talking about good bimanual massage, where I personally like to do my own, where I put my hand in and have one hand on top, and I'm holding that uterus and really rubbing it and kind of compressing the uterine cavity. If that does not work, then we need to start thinking about, gee, well, how do we get this how are we going to take care of this issue? So one of the other ways to put pressure on that uterine cavity is to either pack the uterus or use a Bacri balloon. If those things fail, then we need to be going to the operating room to try to figure out how to control blood supply. That includes maybe placing sutures in the uterine artery, around the uterine artery, or also using uterine compression sutures. There are a number of them. Everyone knows the B-Lynch, but you can actually just sew the uterus from front to back and put sutures in if you're not skilled with the B-Lynch. And then last but not least, but it may be first on it may come sooner or later, depending on the blood supply in your center, is hysterectomy. So let's look at planned interventions. So we do a risk assessment at admission. We avoid delay because we have a staged response. We limit continued treatment. So I never forget this. I went in one night to cover the residents because no good deed goes unpunished, I think sometimes. And my fellow had given 10 rounds of carboprost or our prostaglandin, 10 rounds. And he said, oh, I think the patient is going to stop bleeding. I'm like, oh yeah, she's going to stop bleeding in just a minute. So if those things aren't working, we need to be thinking about what the next intervention is going to be. And we also need to order labs early. This is some work from Larry Shields. Blood product estimates. One of the things, estimated blood loss are low, as I said before. And then delay is likely to occur. You never need just one unit. And then there's DIC and mortality. Once you get into DIC, you really have to get on the stick, because blood is going to, I say when I teach residents, it's like blood in and blood out. If you don't have clotting factors, that's basically what you're doing until you can get control of the situation and figure out what we need to do. Again, including packing the uterus or using a Bacri balloon and being able to effectively use those if you need to get that patient to a higher level of care. Next. So this is our hemorrhage risk assessment. Some places have this built into their EMR. I know that where we are, we have it built in. I'm not sure how often we use it every single time. That'd be a excellent opportunity for quality improvement. So low risk, you want to get just a clot tube to hold. These patients don't have any uterine scarring. They have less than 4 previous vaginal deliveries, no bleeding disorder, and they're singleton. Medium risk patients are those patients I talked about, the multiple gestations, the patients with infection, magnesium use. And then those high risk patients where we need to plan. The other thing that we need to be thinking about, and there was an excellent article on disparities, or excellent presentation at the Society for Maternal Fetal Medicine, is the hematocrit of the patient. If we start with the hematocrit of less than 30, a hemoglobin less than 11, then we're already starting behind the 8 ball, and those patients are at risk. So we need to be looking at those patients way, not on the antepartum side, to decide what type of supplementation they need to get. Next. Now, let's look at readiness. Every unit needs to have a hemorrhage card. What's on your card? It depends on what your unit has available, but at least some vaginal packs, a uterine balloon, or a bunch of Curlex you can tie together, uterine forceps. It needs to be able to be taken places so you can move it around. Diagrams depicting how you're going to do a uterine artery ligation or a balloon placement for people who may not be skilled. It needs to have all types of things on the card, medications, and then of course, other things that you would need to be able to really take a good look at the uterus. Next. Your physiologic goals should be to maintain your diastolic blood pressure less than 80, greater than or equal to 45, and your systolic pressure greater than or equal to 85. If the patient is hypertensive, you need to make sure that you remember that, because this may be too low. You want to make sure that they have received and they get appropriate blood products. You need to have some type of transfusion protocol in your hospital. You want to try to keep their hematocrit above 24 when possible. And your fibrinogen above 100. I personally like a fibrinogen above 200. And I like my INR to be less than 1.4 at least. Usually I aim for an INR of 1.2. Next. We want platelets counts greater than 50,000. We want to maintain the maternal pH greater than 7.2, a base excess of less than -5, because the greater the base excess, the more likely you are to get into trouble, and you want to keep their temperature up. It is really important to keep temperature up because a cold patient drives DIC. So you need to have some type of OB hemorrhage protocol. All patients at all times are in one of these stages, so we need to go through those. Care is divided into 5 stages. 0, they're normal. 1, their bleeding is greater than expected. 2, they're requiring more than 2 uterotonics and they're not responding. 3, they have blood loss greater than 1,500 cc's, they have normal vital signs. 4, they're in recovery. And 5, they're in recovery. And the 5th stage I always talk about in this particular situation is that they remain stable. Last but not least, we want to remember to quantify our blood loss. Remember, we are not very good. And so, you'll ask the physician, how much blood has she lost? We'll say, about 300 cc's. So therefore, we need to make sure that we have the ability to have under-buttocks drapes. And then last but not least, we need to make sure we have the ability to weigh our chucks and things of that nature. Next. These are the things we've already talked about. I include these just for your ability to use them and to have the dosing. One of the most important things we can use is tranexamic acid. Next. It's the new pearl of hemorrhage. This is the woman study, woman trial, randomized control, multi-center, double-blind trial. They administered within 3 hours of the patient delivering, decreasing bleeding and maternal morbidity and mortality, and they decreased the need for laparotomy without thrombotic complications. There has been a subsequent trial that denotes that it doesn't help just to reduce prophylactic bleeding. The dose is 1 gram. You want to give that. over 30 minutes, and you can repeat it in 15 minutes or within 24 hours if hemorrhage reoccurs. That's that stage 5 that we talk about, maintaining the patient after recovery. Next. If we look at it, the impact of immediate treatment was improved survival by 70%. If we delayed for 15 minutes, there was a decrease in survival by 10% for every 15-minute delay. And after 3 hours, there was no benefit. So this is, if you take nothing home from this, please take this, that TXA, tranexamic acid, saves lives and should be available on your unit. Next. Again, like I said, prophylactic use, we were awaiting that randomized control trial. It was #1 at SMFM this year, and prophylaxis does not decrease the risk if you give it prophylactically. Again, we have comprehensive protocols in our hospitals. We have a lower stage of resolution of hemorrhage, decreased DIC, and just an increased persistent or improved patient and physician perception of safety. One of the things I hate is when I'm running around and there's a lot of chaos. If you have these protocols, chaos is reduced. Next. Again, the new recommendations, I always transfuse 1-to-1. A lot of other places recommend at least 6 units of red blood cells to 4 units of fresh frozen to 1 unit of platelets to 5 to 10 units of cryo. I particularly like cryo in an amniotic fluid embolus as it reduces the amount of volume that you use. Next. Again, I'm including these. This is the World Health Organization recommendation for tranexamic acid. Like I said, for every 15-minute delay, there's a 10% increase in mortality. Next. And of course, these are the ACOG bundles for safe motherhood, recognition and prevention, readiness, response, and then reporting. After every one of these cases, there should be a debrief. What did we do well? What could we have done better? What resources do we need? After that case that we had, I decided that we needed to have a hemorrhage, a Belmont, which is a transfusion, a blood-giving device on labor and delivery instead of having to run up to one floor to get one. Next. And again, I include this here, I include the California Collaborative Debriefing Tool to hopefully help you in your ability to debrief. And I also include the hemorrhage care summary flow sheet format, which is actually in all of our operating rooms. And you can copy this from the California Collaborative, their website, and use it at your institution. These are all resources from the California Collaborative. Again, and these resources are from A1. A1 actually has an excellent toolkit for postpartum hemorrhage for a nursing assessment, another place where you can have resources. Next. Again, it's all about communication. During cesarean section, you know, this where we have postpartum hemorrhage, I always turn to my anesthesiologist and say, hey, I think I'm losing more blood than I would like down here. Let me tell you what's going on. So that everybody's on the same page. If I decide to give tranexamic acid, I also call for the massive transfusion protocol. You can always send back some blood, I tell, especially your packed red blood cells. But when you need it in a hurry, keep in mind the uterus needs 500 cc's a minute. It needs to be there and available. Next. So take-home points is defined as excessive bleeding. I think ACOG uses 500 cc's. Some people use 1,000 cc's. But most importantly, it is associated with hemodynamic instability. Every center that performs obstetrical care should have a protocol in place to manage patients with obstetrical hemorrhage, which may mean, hey, we have 5 units of blood and we don't deliver these types of patients here, or we have 5 units of blood and we need to make a urgent decision and pack this patient and get her to a place where they can take care of her. Usual signs of tachycardia and hypotension often do not occur early in pregnancy. Our patients are young and they have extra blood volume. There's also a co-bleeding. The retroperitoneal space is a space that one must keep in mind, especially when patients have a uterine rupture or pull or tether their uterine artery. And then many women have predisposing factors. And because of that, we need to do a better job of assessing the patient ongoing, antepartum, outpatient antepartum, as we talked about, anemia, intrapartum, and then the postpartum period. I've concluded resources for you. Most importantly, I think that these resources will show that postpartum hemorrhage, uterine atony is the #1 cause, uterine overdistension, a long labor is one of the most common causes of uterine atony. Disseminated intravascular coagulation as associated with HELP, as associated with bleeding, as associated with occasionally intrauterine fetal death, but not often. Sepsis and then amniotic fluid embolism. We talked about TXA, early use of TXA, reduced mortality, reduced morbidity, reduce the need for laparotomy, especially in places where blood supply is limited. It should be one of the first things that you think about on your hemorrhage card. Aggressive resuscitation leads to improved outcomes. Again, I talked about that 1-to-1, 1 to packed red blood cells, 1 to fresh frozen. And most importantly, if you identify placenta accretive spectrum, I sit as a member of the Perinatal Quality Committee nationally, and we're going to be looking at having better ultrasound standards because these patients need to deliver in a place where there's a multidisciplinary team used to taking care of these patients with a comprehensive approach. If you find one and you cannot get the placenta out, leave it in, sew the patient back up, and then transfer that patient to a place that deals with this type of intrauterine placental invasion, because they can, even in the best of care, they can lose 9, 10, 12 liters of blood. Next. This is my email, always available, and I've also, I think, hopefully in my references made it into the slide set, so that people can use those to access to better help get their units together. As JCO will be having all these requirements for every unit that does obstetrics, as we said in the past. Thank you for your attention.
Thank you, Dr. Grace. And yes, your references will be available online on tipqc.org. Thank you again. So this is me. I'm your maternal QI specialist for TipQC, and I'm going to introduce Ann Santa-Donato. She is a director of special programs and projects at AWAN and has more than 40 years of experience in low and high risk perinatal nursing. She currently directs AWAN's post-birth warning signs program, including a current Merck Mothers Grant, and leads AWAN's work at Hersha Alliance for Innovation of Maternal Health. Thank you. Please welcome. Are you ready for me to turn it over to you? I can't hear you.
That's because I was on mute. Yes, you can, I can take over now. All right, thank you.
Yes, I'll stop sharing and you can start sharing now.
I'm going to start sharing, thanks. Okay, shared sound and. All right, and thank you all very much for inviting me to come and talk with all of you today. I have been at AWAN for a number of years, and hold on one second. Let me just escape this for a second because this needs to go back to. Sorry, here we go. In all my years at AWAN, I really feel like I've come full circle because my passion when I was in clinical practice was always high risk obstetrics, and as the director of special programs and projects at AWAN, I am focused on everything related to maternal morbidity and mortality mitigation, and the post-birth warning signs program is one of those. So I'm very, very happy to be here today to talk with all of you. So without further ado, I just wanted to say a word about AWAN. I'm hoping that many of my AWAN colleagues are here in the virtual room with us today, and for those of you who may not know about AWAN, we are a professional specialty organization comprised of over 22,000 nurses who work in the specialties of obstetric, neonatal, and women's health nursing. Our mission statement is to empower and support nurses who care for women, newborns, and families through research, education, and advocacy. And our goals are consistent with that mission statement to ensure that we are in the business of promoting diversity and inclusion within our organization, within our profession, and to ensure that we're providing the best care possible for all patients who have babies. Awareness, we advocate for critical issues that impact women and newborns, nursing care, while developing collaborations with communities and other like-minded organizations. We are committed to maximizing our member experience, both from a perspective of clinical practice, from the perspective of education, and also the networking and the communication that takes place within and among the sections of our organization. We are known to be the standard bearer for our specialty in nursing, and one of our goals is to ensure that we continually advance A1 as the trusted leader for nursing research, education, and evidence-based clinical practice. And we can't do that without having a very sound infrastructure. So it's our goal to ensure that we are investing in the people, the technologies, and the facilities that are necessary to advance the mission of the organization. I just want to take a moment to show you a bit of a wide array of products and services that we offer. And I'm not going to take too much time to do this right now because I know we're running a little bit behind, but I just encourage you to go to our website at a1.org, www.a1.org, to take a look at the kinds of programs we offer. And just a word about our sections. We are divided into 51 sections that are led by member elected volunteers, and they are comprised of each of the states in the United States. And we also have an armed services division or section of the organization. Our chapters are local subgroups based on geographic area within the state. And as those of you who are A1 members know, there's tons and tons of opportunities for networking and engagement within your own section and also between the various sections at A1. And so just for more information about that, you can go to membership at a1.org/membership. We have a number of very key legislative priorities, and those are just to show you a couple of them now, to ensure that there is nursing representation on state, federal, and other multidisciplinary task forces, advisory boards, working groups, and maternal mortality review teams, and to expand research funding and opportunities to investigate and alleviate the causes of maternal morbidity and mortality. So you can go to, again, our website and /advocate to get more information about that. So without further ado, I want to really get into the heart of this discussion today and talk about our A1 post-birth warning signs program. And if someone would kindly put the URL for post-birth on in the chat, that would be great. So this slide has been presented earlier today. Dr. Goffman did a wonderful job of really kind of setting the stage and outlining the significance of maternal mortality, as did Dr. Graves. One of the things I want to point you to, however, is despite the fact that we had a slight dip in the maternal mortality rates over the last couple of years, that those rates are once again increasing. So we still have so much work to do to reduce and eliminate maternal mortality in this country. This slide has also been alluded to, so I'm not going to spend too much time here, but this is really one of the alarming statistics that compelled A1 back in 2015 to really start looking at post-birth warning signs and complications very seriously. Cardiovascular disease right now is the #1 cause of maternal mortality. Sepsis is actually #2 in the CDC statistics, so these are the national statistics, with other non-cardiovascular conditions such as chronic disease and illness that really contribute to significantly to both morbidity and mortality among women. And then, as you can see, cardiomyopathy, hemorrhage, thrombotic pulmonary disorders and pulmonary embolism, cerebrovascular accident or strokes, hypertensive disorders of pregnancy are all still on the top of that list of the chief causes of pregnancy-related death in the United States. This information comes from the Building U.S. Capacity to Prevent Maternal Deaths, and this is from 9 maternal mortality review committees. And again, as other speakers have talked about, the tragedy and the opportunity is that over 60% of these maternal deaths are deemed to be preventable. And so that was a second driver for us to really take a serious look at post-birth warning signs. We have to keep talking about the disparities in maternal mortality in this country. As you can see from this slide, Black non-Hispanic women are up to 3 times more likely than white women to have a maternal death. And similarly, American Indian and Alaska Native non-Hispanic women are up to 2 times, at least 2 times more likely than white women to have to experience maternal mortality. So this is information that we included in the original post-birth warning signs education program, but we've actually expanded significantly upon this information in the program that we just released, the 2nd edition program that we just released in January. So I'm going to take a few minutes to just give you some highlights, but not the in-depth discussion that we know we should be having about disparities and the influence of bias and racism. This content is included in the program as well as much more in-depth discussion. So we know that Black women are more likely than white women to give births at hospitals that have high morbidity rates. And unfortunately, the literature more and more is showing that among all of the other inequities and disparities in maternal health care, that many Black women find that and have reported that their reports of pain and other abnormal signs are being ignored. So the issue of disrespectful and dismissive care comes into play here. Same for Native American women. They frequently experience discrimination and bias in the healthcare they receive. And for too many Native American people, the lack of access to care is a significant issue. So it's a lack of access to care, to services, and especially those who live in rural areas. Multiple causes of inequities, as many of the speakers today have really talked about, which is the impact of implicit and explicit bias and racism, which many times results in disbelief and distrust and miscommunication between providers and the patients, where the patient's concerns are either not taken seriously or they are dismissed altogether, and a misconception by providers about pain tolerance among Black women. And so not only are there signs and symptoms being ignored, but there is a certain degree of skepticism that is inherent in some of us providers about that Black pregnant women do not experience pain in the same way that white women do, which sounds absurd, but that's what's been borne out in the literature. So it's something that we have to pay attention to. Again, these have been already alluded to, so I'm not going to spend too much time on this, but unfortunately, there is still very high societal indifference to racism and discrimination. And we still, in terms of the social determinants of health, there's, people of color continually experience unequal access to housing, employment, education, and equal pay. We know that pregnancy is a stressful time, and for some women, pregnancy can be a very good stress, where you're starting out on a new pathway to begin a family, to decide and define what the rest of your life is going to look like with your partner. But it can also be a time of very high psychosocial stress for women of color in particular, to navigate their way through that pregnancy with or without the resources they need. And Dr. Goffman also pointed to this statistic that younger age, higher socioeconomic status, and level of education do not reduce maternal mortality among Black women in particular. And that's a very important point to keep in top of mind, that no woman of color is immune from from the complications that occur during pregnancy that can result in maternal mortality. Unfortunately, we don't have time to show you the brand new A1 video that we've just produced or our new birth equity website, but I want to make sure that all of you are aware of this. So if we could put the URL for our birth equity website in the chat, that would be great. This video was produced as part of the work that we're doing with a Merck for Mothers grant, which is multi-year and multifaceted program. And so we're very grateful to Merck for Mothers for their support of the development of this video. This video really highlights the lived experiences of two Black women who received disrespectful and dismissive care during their pregnancy and their postpartum period. And you know, Dr. Graves, you alluded to, or you talked about the need to be very, very attentive to concealed hemorrhage. And one of our two moms, in fact, had a concealed hemorrhage that was ignored. And so she almost died, and she thankfully is here with us today to talk about it. The other person is a faculty member at one of the universities on the East Coast, and she also received very disrespectful care, had some postpartum complications, and she talks about her experience too. So I encourage you to access this video. You can also access it via YouTube, and just do A1 and then YouTube and you'll find it. Okay, so thank you for that. All right, so talking about the timing of maternal death related to pregnancy is also very important because, as you can see on this slide, over 60% of the deaths that occur as a result of pregnancy complications occur within the first year following the birth. The greatest majority of those occur within the first 42 days, but there's still a significant proportion that occur up to the first year of life of postpartum, sorry. So we started this work in 2015 by doing a pilot project, again, supported by Merck for Mothers. And we set out to investigate and really explore what is currently being done, what was currently being done at the time to prepare moms to go home from the hospital. And so what we found in the first pilot study through a series of very focused focus groups is that the majority of educational messages are focused on the baby for many nurses working in the facilities that we queried in both New Jersey and in Georgia. And so, you know, obviously it's critically important to ensure that the educational messages about newborn care are are included in all of the postpartum education. In addition to that, the nursing staff was focused primarily on all of those normal things that happen during the postpartum period. So ensuring that mom is aware of breast care, that the mother is aware of lochia and how to care for herself following the birth of the baby. So all of those things that are normal parts of postpartum care, those were being covered pretty consistently across the board. However, when it came to post-birth warning signs and talking about potential complications, women were receiving inconsistent or inaccurate information about those types of complications, and hearkening back to looking at those, the top causes of maternal mortality. And that the education provided does not necessarily focus on the warning signs for postpartum complications. The other thing that we found pretty consistently in the focus groups was that, by and large, the warning signs were taught to women who were believed to be at increased risk rather than for every postpartum woman. So that was the stimulus for us to start developing our program. The key messages that we set out to convey as a result of the findings from the first pilot study were to ensure that mothers recognize the signs and symptoms of childbirth complications that can occur following hospital discharge, to be able to respond by calling 911, going to the nearest hospital, urgent care, calling a healthcare provider, depending on the situation, and then helping postpartum patients remember to tell their healthcare provider, including any emergency personnel, the date of their childbirth or the presence of a pregnancy within the last year, because to ensure that that provider understands that the symptoms that the mom is presenting with could be related to postpartum complications. And so the goals of our program are threefold, primarily to raise awareness and educate nurses and other providers about the key postpartum complications and warning signs, to empower women to know the signs and get care quickly using a standardized parent education process, and then to ultimately ensure that all healthcare providers are involved on some level in educating women and their families about post-birth warning signs. And Dr. Graves, you alluded to this before, and this the performance measure for PC06 for hemorrhage, and also similarly for hypertension, I'll go there in a moment, is to provide education to patients and their families, including the designated support person, whenever possible, and that education includes signs and symptoms of postpartum hemorrhage during hospitalization that alert the patient to seek immediate care once that patient goes home from the hospital. And then similarly to, once the patient has been discharged, to ensure that education is provided that will help them understand what's going on and to identify and recognize those symptoms at home. The piece, the EP6 for severe preeclampsia is very similar. So I'm just going to run through this very quickly. That the education again includes signs and symptoms, and those to be aware of if you've had a complication, and also those to be aware of when you go home, regardless of what your risks were prior to. We're very, very proud also that the literature to support these recommendations comes from both ACOG and their optimizing postpartum care and treatment practice bulletins and committee opinions, but it also includes the outcomes articles from our initial pilot projects. And then this also includes when to schedule a postpartum discharge follow-up appointment. The program components for post-birth warning signs include our online education course, which we've just updated and released in 2021 in January. The Save Your Life handout, which is the parent handout, and magnet template so that facilities can make their own magnets or hard copy magnets. And the template is the Save Your Life handout, and the template are available in English, Spanish, Arabic, Mandarin Chinese, and Haitian Creole. The Save Your Life parent education handout is on our post-birth warning signs landing page, and that is available as a free download for anyone who's working in a healthcare facility to be able to use that either independently or ideally having taken advantage of our online course, but to use that Save Your Life handout within facilities, whether it's inpatient or outpatient, to help guide teaching. The program also includes a nurse post-birth warning signs education teaching guide. Now, I use the term nurse a little bit loosely because while we know that nurses are in contact with patients most frequently, we also know that health educators in outpatient facilities may be the ones who either provide this education or reinforce the information that parents have received in the hospital. So, but the teaching guide I will also show you in a moment, and to show how that document can be utilized. We have a toolkit also that has additional resources beyond those that I'm showing you here in terms of what facilities can utilize to implement their own quality improvement projects. And so they contain things like a standardized but modifiable QI audit tool, letters of support to justify bringing a program such as this into your facility, an opening or an introductory presentation that can be utilized in the facility to gain buy-in, and then a poster presentation that can be utilized. So there's a number of a variety of different resources that can be utilized. And then the resources that we have include all of those outcomes articles that I've alluded to. In addition to our own journals, there are also one of the outcomes articles is published in the Maternal Child Health Nursing Journal. And then we have consumer information on our Healthy Mom and Baby website at healthforwomen.org. So why standardized education? Well, it's important to do this to help improve nurse and provider communication in general, so that everybody's speaking the same language when we go in to teach or reinforce information about post-birth warning signs. And that we ensure that we're being consistent about teaching all women about post-birth warning signs, because we know that now that even among women who don't have pre-existing identified complications during pregnancy or the intrapartum period, that these women are all women who have babies are subject to risks and complications following the birth of the baby. And then the third element was to ensure that we as providers are saying the same things, essentially, to be able to, obviously, while individualizing the care that's provided, we still need to make sure that we are being mindful of the need to ensure that women are getting consistent information. And then to facilitate postpartum discharge education and follow-up in the aftercare setting, whether it's in an outpatient clinic or whether it's in a private physician office or a nurse practitioner's office, to make sure that this is available to clinicians to either provide for the first time or to reinforce education that folks have been given in the hospital. And then to be able to obtain valuable data, for those who decide to do facility-wide implementation, it's really important to make sure that information is gathered, that data is gathered for compliance, to make sure that all postpartum patients are being given this information, and then to find creative ways of looking at whether or not this education is really having a positive impact on reducing morbidity and mortality. So this is a copy of the post-birth warning signs handout, of the Parent Education Save Your Life handout. And one of the things that we learned as a result of the collaboration we have done in the Merck for Mothers project with our partner organizations such as the NBEC, the National Birth Equity Collaborative, and the Black Women's Health Imperative, especially as it relates to Black women's experience of care during pregnancy, childbirth, and then the postpartum period, is that we created this form 3 years ago. We are setting out in 2021 to modify this form slightly and change the name of the form, because they were very astute at bringing to our attention, and it has become a mantra now, that while we are setting out to empower women to take care of themselves, that it's not their job to save their own lives. I think you can all relate to that. So this will be around for another 8 to 10 months or so, but we will be updating this. The content will not change significantly in terms of using our acronym post-birth. The premise of this is to ensure that birthing people who go home from the hospital have a point of referral to say, when do I need to call 911 and when do I need to call my healthcare provider? One caveat that we want to make sure is being covered during these education sessions is to ensure that mothers know, and their significant others know, to trust their own instincts. So the bottom line is, if a mom is not feeling well, feels that something's just not right, to be able to trust their instincts to access care, to call a provider and say, this is, I'm feeling this, I just don't know what to do about it. What is it? So that we make sure as healthcare providers that we are not engaging in that denial and delay that results in morbidity and mortality. I think it's better to receive a phone call from your patient and help that person differentiate what may be a normal sign of postpartum discomfort versus what could be a sign of a complication. And then to ensure that moms know when they enter the healthcare system to relay that they have been pregnant within the year or just given birth. So you can see in the acronym that these signs that we're asking people to watch out for are consistent with the complications of pregnancy, that we're focused on in terms of CVD, postpartum, pulmonary embolus, VTE, hemorrhage, severe hypertension, sepsis, and postpartum depression, which is not on the CDC list of primary causes of maternal mortality. But as Dr. Wood pointed out, it's a significant contributor to morbidity and mortality in the postpartum period. And then the other part of the acronym, the BIRTH acronym, speaks to those signs and symptoms that are very problematic, but may not require 911 call, or may be that you can contact the healthcare provider to get information you need and to get a next step or direction from your healthcare provider. The education guide is, I'm going to show you some blow-ups of this, and this is where the standardization comes in. We created this document to help guide the conversation that the nurse or the other clinician has with the patient regarding what to watch out for and what to do about it. So I'm just going to show you a couple of examples of this. So for pulmonary embolism, for example, this is the standard format that we use to identify what is that problem, what is the sign of pulmonary embolism that I need to be aware of, and whether I need to obtain care immediately by calling 911, or whether the signs or symptoms that I'm experiencing are such that they can be referred to the healthcare provider. So here's another example, same format of what is it, how do I know I have it, and then how do I obtain care immediately. A third example, for example, and again for infection, just so that you can get a flavor of the essential teaching elements that should be included in these sessions, and to really focus on the fact that you as a healthcare provider should be comfortable with this content, so that this is really a teaching guide. It's not a script. We don't want anybody to be rattling this off verbatim. So I just wanted to make sure I emphasize that for all of you, is that we have a standardized format that you use in your conversation with the mom before they go home from the hospital, or in the postpartum care setting. One word about COVID-19. We were starting to get last year a lot of queries about one of the elements of our Merck project is that we're disseminating the post-birth warning signs education and implementation in 100 hospitals around the country. And so we were starting to get a lot of questions about, well, how can we do this in the middle of COVID? And, we're can't do all this education. And it's not really the top priority. And we were getting queries from all over the place about this. But as an organization, we felt it was really important to emphasize the fact that post-birth warning signs education is as important during COVID as it is before this pandemic ever started. And the key element here is that many of the signs of post-birth complications are the same as signs of COVID-19. So helping parents understand before they go home from the hospital that you could experience as signs and symptoms that are directly associated with postpartum complications, and ensuring that if that person has to go back to the hospital for care, that they then feel empowered to make sure that the ED personnel or the EMTs understand that they have just given birth and I'm having a headache like I've never had a headache before. That helps the EMT or the ER person, the ER provider, to begin that differentiation process. So is this COVID-19 or is this a post-birth warnings or post-birth complications sign? So we felt strongly enough about it that we published a statement about it. And that is also on our dedicated COVID-19 page on our website. So before I conclude, this is about a 2.5 minute video that I want to share with you. Or Bonnie's shaking her head. Do we not have time? Okay, I know we were 15 minutes ahead. We were 15 minutes over time before I started. So am I over my time at this point?
5 minutes ago, we had 3 minutes left. Amanda?
Okay, so.
Yeah, if we want to do Q&A, we'll need to pause.
That's fine. Yeah, that's perfectly fine. This video is available. You can copy the YouTube URL, and it's also available on our post-birth landing page on the website. So I'm happy to forfeit that for the moment. Okay,
Thank you
that's
so
cool.
much.
So let me take my slides down.
So much, Anne. We really
You're quite welcome.
you. And we really appreciate A1 and how A1's work really overlaps with our goals and our missions at TIPQC. So thank you so much. We have a couple of questions that were already chatted in. The first one is for Dr. Graves. So this one, though measuring EBL and diagnosing postpartum hemorrhage is sometimes difficult and difficult to determine EBL exactly, what is the difference in the incidence of postpartum hemorrhage when using estimated blood loss versus quantitative blood loss?
Well, I think that we all know that estimated blood loss is our own estimate. And so therefore it may be, it's very difficult to know, and that's why postpartum hemorrhage is often underdiagnosed. Quantitative blood loss is an objective method of being able to diagnose postpartum hemorrhage. And I think in this country, as we began quality improvement and quantitative blood loss, you saw an increase in the diagnosis of postpartum hemorrhage, not because there were more people bleeding, but because there were more people being diagnosed. So my preference is to have a ability to do quantitative blood loss and to do it at all times. Like I said, as OBs, we see blood all the time. So, blood all over the floor. We're like, oh, well, that's 300 cc's when it's really, 1,500 cc's. So I think that quantitative blood loss will increase your accuracy and make it better for the patients.
This next question is for Dr. Wood. How do you determine if someone needs medication during pregnancy? And how do you counsel on SSRI use in pregnancy?
So I'd say if you have someone who's pregnant and is in an acute episode of depression, usually when they're coming to me, I am restarting people on medication. I think it's a lot harder to have somebody who hasn't previously taken medication have a depressive episode during pregnancy and start them on medication de novo because you don't know whether or not it's going to work. And all medication is really a risk-benefit equation. And so this is a much easier determination to make if you have somebody who's been on a medication before, had a good response, maybe came off, now is depressed, and you're restarting something, feeling pretty confident it's going to work again. I have two different approaches for counseling people about SSRIs during pregnancy. When I was in residency, I trained with the perinatal group up at Massachusetts General Hospital, and we spent a lot of time talking to women about the risks of medication during pregnancy, going into a lot of detail. And I find in my current practice that a lot of people don't necessarily want to have quite as an in-depth conversation. I tell people basically that there's no increased risk of birth defects, that birth defects are present in about 3% of infants, and this is not increased by medication. I do talk to people about the possibility of an increased risk of PPHN associated with SSRIs, although the data is somewhat mixed on how great that risk is. And I also talk about kind of this what I call neonatal adaptation syndrome. A lot of patients will refer to it as withdrawal, but there was a paper that looked at infants born to moms who actually stopped antidepressants in the third trimester, so well before, in the second or third trimester, well before delivery. And these babies had the same incidence of neonatal adaptation syndrome as babies who were exposed to SSRIs throughout the whole pregnancy. And so I usually tell people about that, that it's not necessarily a withdrawal. It happens with babies in Prozac as well as babies in Effexor. And so try to provide a lot of reassurance because I do think that there's a ton of study, there is a ton of study of SSRIs during pregnancy. They've probably gotten more scrutiny than any other medication out there.
Thank you. This next question is for Anne. How does my hospital sign up for the post-birth warning signs?
You're muted, Anne.
Sorry. Yeah, so the if you have inquiries about how to get started using the post-birth warning signs program, I would refer you to Mitty Songer, who is our Director of Client Relations and Sales at A1, and she can be reached at msonger, S-O-N-G-E-R, so it's all one word, msonger@a1.org. Thank you. Yeah, and then
Still providing those through TIPQC. So actually, if you go through
Yes.
Brenda, we will cover the cost of that. So
We'll cover for 10
Oh.
seats, and then the kit and everything. So yes, if you get with Brenda Barker, then we will be happy to help your facility to get the
Right.
post-birth warning sign kit.
Correct, and that's how I ended up coming to this presentation today. So yeah, we are working with the state to start implementation. So thank you for that reminder, Bonnie and Amanda. But then if people have clinical questions related to post-birth warning signs, they can contact me directly, and that's also on that last slide. Thanks.
Thank you. Our next question is about Tennessee's inclusion of extended postpartum care in the budget. And will that change the scheduling of checkups? Or will that mean the patient will need to self-identify and request to be seen? So I think I would love to hear any of the panelists' thoughts on this. I know at Vanderbilt, we are changing our postpartum care follow-up plan to align with ACOG's 4th trimester recommendations. And so having a 1 week follow-up for those identify high-risk women, having a 3-week follow-up for everybody, 2 to 3 week follow-up, and that could be telehealth or it could be in person, and then having a 12-week, like within that 6 to 12 week frame, a comprehensive postpartum visit, and then launching that person into their annual well woman care, and really using that time to also facilitate relationships with other specialists or primary care physicians that we need to get patients into. Anybody else have thoughts about this? Dr. Graves, can we start with?
Actually, I agree. I think we have adapted the 4th trimester, but I also have a postpartum preeclampsia clinic. And one of the things that has been an issue is that I have to get people in, right? I have to get them in if they have, 10 care, because they only have 8 weeks, and I got to get them to the cardiologist, and I got to get them consulted. And then it's harder to do a handoff to their PCP. So I'm hoping that this extension will allow us to do better continuity of care, and especially for patients with hypertension and diabetes and preterm labor, who all are at risk for cardiovascular disease, which we've talked about all day, the ability for them to have continued care in the system. So not only I think we'll be able to give postpartum care, but also the hope that we at least get them to establish some type of primary care for long-term health.
Yeah, it can potentially really launch people on a path for better overall wellness.
Right.
In general.
And prevention.
Mm-hmm. And this is, if I would like to just add to that, if I may, to this is really a call to action time for all of us, because the Momnibus bill is being reintroduced into Congress this year. And so I would really encourage all of you, whether you're ACOG members, ACNM, A1 members, to go to your legislative action centers and to provide your support for the passage of this legislation, which includes, among many, many other things, that are designed to improve healthcare for all women, but also for women of color. One of the provisions in that bill is to support increased funding for the extended postpartum care period. So I really encourage everyone to go to your legislative advocacy centers within your own organization, or independently contact your elected representatives to support that bill.
Dr. Wood, how will this postpartum extension for 1 year postpartum help our women with mental health disorders?
I don't know if I'm plugged in enough to be able to answer that question. Being totally out of the system.
I think just, I mean, having insurance is always helpful to.
Yes, I mean, I know that our community mental health clinics here in East Tennessee have really been working hard to expand services for pregnant and postpartum women. I know Helen Rose McNabb previously had a program where they were able to help women who were in recovery from I think, well, substance use disorders, primarily opioid use disorder, and they have now trained up people to be able to expand to help all women with, well, pregnant and postpartum women with mental health problems, and also women with commercial insurance, as well as simply TennCare. So services are expanding, which is great.
Bonnie or Amanda, do we have any other questions? I'm going to turn it over to Bonnie.
Yeah, I don't see any more questions.
Thank you. Maternal Focus podcast topics to date. So TipQC does have a podcast, and Amanda Nally is wonderful at facilitating those and getting everybody connected. So far we've had the CDC Hear Her campaign, post-birth warning signs, a mom story with KK Dixon, and the IPP LARC in Tennessee. And this is where we bring our providers and our state leaders together, and people of who this is their niche, right? It spotlights discussions with industry experts, and so far we've focused on OUD, OEN, and the crisis, but we've had safe sleep for babies too. So it really is a great thing. And there's so much more to come. So if you look for your podcast on whatever device you listen to, we would love for you to join us. Later on today, about 4:30 to 6:30, which just started, is the optional learning session. So if you want to see the Tennessee Breastfeeding Coalition, please click that link. It is with Laura Hutton and Tiana Piles, and we would like for you to join them as well. Tomorrow's agenda will welcome you back at noon, and we'll continue on to 5 o'clock, and that is on our TipQC site. And we want to thank you all for participating and sharing your hard work, and we hope to see you tomorrow. Thank you so much for joining us. And if you have any additional questions, please leave them, and we'll get them back to you answered by the provider that you asked to answer it. Thank you so much. Have a wonderful day and be safe going home. Bye, guys.
Bye. Thank you.
Thank you.